Hello, everybody, and welcome to today's presentation. Thank you very much for being with us. Before we introduce today's speaker, let me just let everybody know that the audience will be in listen-only mode during the presentation, but there will be a Q&A session after the fact, so please do go ahead and submit your questions in the chat box. Today's presentation is titled ExoDx Prostate Test for Risk Assessment of High-Grade Prostate Cancer. And it's an honor and privilege to me to introduce today's speaker, Professor Alexander Hese from the Martini Clinic in Hamburg, where he is the head of robot-assisted urologic surgery with more than 3,500 personal surgeries under his belt. But he also has a long track record of research in biomarkers, which is today's topic, all the way back from the doctoral and habilitation thesis on the topic of PSA and kallikrein-2. So truly a long history in the field. So we're very much looking forward to hearing your perspective, Professor Hese. And without further ado, I'll hand it over to you.
So, hello everybody. Thanks for joining us on this presentation about the ExoDx prostate test for risk assessment of high-grade prostate cancer. My name is Alexander Hese, and I'm happy to walk you through a scientific presentation in the next probably 35 to 45 minutes. A few disclosures that I always have to do, which you see right here. Let me just go through the agenda briefly. We will go and discuss the well-known clinical need that a biomarker nowadays has to do for prostate cancer detection. I will discuss what exosomes are, show you some data on the ExoDx risk assessment, clinical studies of the test in how it's used in daily practice on various clinical scenarios. We will go through issues like competing markers, magnetic resonance imaging, and combinations of markers, and briefly summarize the talk afterwards. Most of all, and everybody knows this, is the well-known need for prostate cancer biomarkers is massive. We have the idea that this marker should increase the probability of an initial positive biopsy. It should reduce the number of unnecessary repeat biopsies by better distinguishing benign from malignant disease, stratify ideally low from high-risk tumors, and moreover, assess and help us in staging the disease and classifying its extent, and finally, even to do some therapeutic monitoring. All together for one marker, it's clearly that this is a massive task. Now let's look at the first 3 points, and let's look at them in clinical practice. What you see as a patient, as a doctor, is the typical scenario. You have a patient sitting in front of you, which are usually stratified by PSA because people have their PSA, and you have risk factors, for example, age, and these are pre-selected patients. Now we have 3 patients, A through C, very similar looking, same age, give or take the same PSA range, and still not everybody of these will need a biopsy. And the question is, which of these ones truly need a biopsy? Now let's look at this chart flow, and let's discuss a little bit what we have at our disposal. And here you see the typical pathway of a patient beginning in the upper left-hand side who has a suspicion of prostate cancer, usually based on PSA. And the first question is, how do you decide whom to biopsy? And for this, we have a couple of markers available: 5, 4K, MIPS, Select, MDX, ExoDx, and Prograrix, just to name some of them. And the first thing in this decision tree is to say the result of the test that we have might classify a patient into having a low or high risk of having prostate cancer on biopsy. Subsequently, when we have a biopsy done, we can have a negative biopsy, which then brings us to the point where we ask, do we need to, and whom do we need to re-biopsy? And we look at a couple of markers available for this purpose here again, or in case of a positive biopsy, whom to treat. And we have some risk stratification with some genetic tests, but again, 4K and ExoDx might play a role in here as well. The ExoDx prostate test is the one that I will talk to you about today as the major part of this presentation. And I just give you a brief introduction on it. It's a standalone test for men age 50 and higher with a PSA range 2 to 10, which are considered for prostate biopsy. It assesses the patient's risk for high-grade prostate cancer defined as Gleason score equal or greater than 7. It's non-invasive, urine-based assay, no DRE required and no prostate massage. And it's included in the NCCN guidelines for early detection of prostate cancer in the initial and repeat biopsy setting. The first question is, what are exosomes? We know what PSA is. It's a protein. We have RNA tests like in urine tests, but what exactly is an exosome? And you have to imagine that the idea that an exosome is kind of a way with which cells communicate. We all know the typical communication of cells being endocrine, paracrine, neuronal, or by contact-dependent mechanisms. And the communication via vesicle, via exosomes, is a fifth form of cellular communication, in which you see on the left-hand side a vesicle, a microvesicle actually in a secreting cell, and this microvesicle contains basically all kinds of substances. These are excreted from the secreting cell into the cytosol as so-called exosomes, and the receiving cell incorporates this information and brings it back into its inner. So that's another way of communicating for cells. And this is these small particles here, these are exosomes. Exosomes are therefore released by normal and cancerous cells, by all living cells actually. They're produced by eukaryote and prokaryote cells. They play a role in health and disease. They can deliver molecules not normally secreted from cells. They can contain RNA, DNA, proteins, and these markers allow secreting cells to be identified, and it can be collected from any body fluid. And us being urologists, our body fluid obviously is the urine. So in practice, what is the test works that you would collect a 15 milliliter urine sample and send it out. And during the processing, there is a patented exosomal RNA extraction, and the EP testing is performed with doing tests for PCA3, SPDF, or ARC, to name these three. Multivariate algorithmic analysis is done, and quantitative RT-PCR. And what you receive on the other end is basically a score that reaches from very low to very high, and that indicates your risk for high-grade prostate cancer. So in practice, the ExoDx Prostate test delivers this score from 1 to 100, and it's important to realize that it is different from any other factor that you might contemplate, such as age, ethnicity, or family history, for example, to help you assess a man's risk for high-grade prostate cancer. It should be used when you consider a biopsy initially or repeat, and it has a sensitivity of like 92% and a negative predictive value of 89%. The cut point for this test is determined at 15.6, which means that any score below 15.6 means that the likelihood of high-grade cancer is rather low, and the possible next step would be monitoring, or a score above 15.6 means that possible next steps should be MRI or biopsy, because the risk of high-grade prostate cancer is increased. Let me show you, why can we say this? What is the database behind our claim? And I will walk you through a couple of studies. The first one, JAMA Oncology, and the second one being a European urology study. Both are prospective clinical validation studies that intend to use patient populations of about more than 1,000 patients from the United States. The validation study resulted, and they are published, as I said, in JAMA Oncology and European Oncology, and they demonstrated overall a significant, about 27% reduction in unnecessary prostate biopsies. It does discriminate between high-grade and low-grade disease and benign disease, and it was associated with improved identification of patients with higher-grade prostate cancer among men with elevated PSA, and it could reduce the total number of unnecessary biopsies. Let's look at the JAMA Oncology study first. The age description, 50 and above, PSA range 2 to 10 nanograms per ml, training cohort 499, validation cohort about 1,000, and included were 255 and 519 respectively for the validation studies. This cohort, it's important to note, is representative of real patient population with a median PSA and a prostate cancer prevalence of 48%. The outcome of the study basically looks at the area under curve for clinical significant risk assessment first. And if you compare the result you received by the ExoDx compared, for example, to prostate cancer prevention trial calculator or the ERSPC calculator, both of which are also risk assessment tools, or for the PSA, then you could clearly see that the area under curve of the ExoDx is significantly higher than the other factors I just mentioned. Therefore, it is clearly safe to say that it is an independent clinical factor and that you could probably consider it putting it on top of risk calculators if possible. Let's move forward. The performance of the ExoDx of identifying patients at low risk for high-grade prostate cancer is depicted here. If you look at the left-hand side on the cross table with a Gleason score below, equal or 7 or above, then ExoDx above a cut point was found in 136 patients and only in 12 below the ExoDx cut point, which means overall a sensitivity of 92%. The other way around, negative or only Gleason 6 on biopsies was found in 126. Added to these, the 12 false negative means a negative predictive value of 91.3%. So in other words, what this test does, that it has most false negatives of these 12 were Gleason 3+4 with less than 3 positive scores. So kind of the better one of the high-risk diseases. And the real high-risk disease defined as 4+3 or higher had a negative predictive value of even 97%. And finally, the EPI correctly identified 126 patients with Gleason 6. So these are quite compelling data. The next scenario that we are looking at is patients, of course, with the prior negative biopsy. And for this, we have this BMC urology publication from September 2020. Here, we can say that, or we can take part of the conclusion beforehand, EPI stratifies high-grade prostate cancer risk in men with prior negative biopsy. The cut point of 15.6 defined earlier, sensitivity of 82 and negative predictive value of 92%. I show you this in the respective bar graph right now. It avoids about 27% of unnecessary repeat biopsies, and only 1% of greater or equal Gleason grade 3 would have been delayed detection. And therefore, compelling data very similar to the initial biopsy setting, with reducing about 35% of unnecessary repeat biopsies. Overall, if you could look at a sort of decision curve analysis, it shows you on what you see here on the right-hand side that the EPI, based on biology independent of other clinical risk factors, as I said, has overall higher net benefit compared with PSA or clinical only models, such, for example, the ERSPC calculator, to select patients properly for biopsies. The next study I will walk you through is a clinical utility study. Unlike the previous one, it is more designed to analyze how patients' management changes when you use the ExoDx test in clinical practice. What this study does is basically it assesses how the ExoDx Prostate test has, what the impact it has on shared physician or patient decision-making. We had about 1,100 patients, and they were randomized between two groups. I will show these to you later. Inclusion criteria were the same, 50 years, PSA 2 to 10, as before, scheduled for initial biopsy. And this is basically the flow of the clinical utility study. So you had patients were enrolled, and urine was collected on standard criteria. And then all patients had an EPI test done, but the randomization was done to have one arm that receives the EPI test result and would go forward based on the EPI test, and the other one, the control arm, did not receive the EPI test result. And then the impact of the EPI result on the decision-making of patient and physician was analyzed. So this is how you have to read it. In those patients who have received the EPI result, 458, there were all in all 93% had a low risk by EPI tests. And in these 93 patients, 36% deferred their biopsy because of this. In total, when you look at this one, these 63%, total 54 had in fact no biopsy done, and therefore altogether combined with those patients who had a biopsy recommendation but did not go through a biopsy, all in all 74% of men with a low risk EPI had not done a biopsy because of the EPI result. The other way around, in patients with a higher risk of high-grade cancer based on EPI, the number of patients who received a biopsy because they were suggested to do so because of the high EPI score, 66% actually followed their recommendation. If you summarize this then, this means that, and you look to summarize this, you compare it on this graph here, you see that the 15.6 threshold is the blue line here, and the yellow line is the standard of care arm in which you biopsy patients without any hint based on the EPI test. Now, here's the standard of care arm highlighted in yellow. And now in those patients, because of a low risk of prostate cancer, because of the score was below 0.6, the decision rate to go for biopsy was much lower than in the standard care arm. And this is appropriate because in the light blue area, you see that the risk of high-grade prostate cancer is pretty low. Conversely, if you look at the population of patients with an increased risk of prostate cancer, also the compliance was following much better than in the standard of care arm. And again, this was a very wise decision because you see that the incidence of the high-grade prostate cancer was much more higher. So in other words, based on that analysis, you could see that patients are more easily driven into their, for them respectively, right decision for not having a biopsy when the risk is very low, compared to having a biopsy when the risk is high, as compared to the standard of care arm. In summary, when you look at this clinical outcome, a utility study, you could really overall say that the ExoDx resulted in a significant increase in patient compliance with the physician recommendations. 92% of patients complied to defer biopsy based on physician recommendation, and 72% complied to proceed to biopsy based on physician recommendation versus only 39% in the non-EPI arm. And because of the increased compliance, the ExoDx also captured 30% more high-grade prostate cancer than standard of care arm. If you look at the comparison within the three studies, and you look again at what you call the area under curve, this is the first validation study, JAMA Oncology, second one in European and the clinical utility study, you see that the area under curves in these three different patient populations is very similar, which suggests that the data obtained so far for the EPI test is pretty robust across different studies within the difficult but important gray zone of PSA between 2 and 10 nanograms per ml. A nice thing about the EPI, again, is also that it correlates with the incidence of the high-grade prostate cancer. So if you see here the EPI score on the x-axis and the high-grade prostate cancer risk on the y-axis, it's pretty easy to see that the higher the EPI score is, the higher is the chance of high-grade prostate cancer. So this makes pretty much sense and looks compelling. If you order a test, then this is what it looks like in real practice. You have the test report, in which you, of course, file all the relevant information for the patient. And then you get the score down here, and you get a sort of an interpretation, which basically tells you again that the score, for example, in this patient is below a cut point, and therefore the risk for a high-grade prostate cancer is pretty low. It is important to note that, of course, other clinical factors should be used to determine whether to proceed with a biopsy, but this is the information that you have in hand to help you make this decision more appropriately. Now, this is the last slide I showed you before. This is the patients which are looking so very similar based on age and PSA, and probably based on the data we can say here that from these patients that we are referring and which looked so similar initially, there's indeed a patient who does not need a biopsy because of his EPI score, and there's certainly patients who are in need for a biopsy. So what this test does is really one other test to tell that the selection of patients can be done more precisely when you use an EPI test. So, preliminary summary so far, the ExoDx, we can say, is a non-DRE urine-based liquid biopsy genomic test to assess the risk of high-grade prostate cancer in men 50 years and older, PSA 2 to 10, considering initial biopsy pre-MRI. We have relevant clinical validation data and utility studies and publications supporting the use of this test for biopsy patients, and it can avoid a significant number of unnecessary biopsies. So far, so good. But is this really the full picture in the world of biomarkers? And what is with the multiparametric MRI? Have we seen all when we have seen the EPI test? And we have to say, no, we did not. We know, and all of you know, that there's multiple commercial markers available. You have the PHI test, 4K, Select MDX, ExoDx is here, MIPS, Proclarix, PCA3, etc., based on blood, based on urine, sometimes based on tissue, and they have been analyzed in multiple settings, for example, pre-initial and repeat biopsies. Most of them have in-point prostate cancer or high-grade prostate cancer. Some have 10-year metastasis-free survival. And if you look at the entire area under the curve of all these tests for the specific outcome of interest, it is noteworthy to say that these tests and the area under curve are not too different from each other. It's important to realize this, and because this basically tells you the area under curve gives you a first approximation on the utility of a test. Just to give you an example, we have shown EPI correlates with prostate biopsy incidence, but so does the PHI test. We see here the correlation between positive biopsies and the number of and the PHI score. So the higher the score, the more likely positive biopsy. Or we have things like the 4K score, just to give you a brief summary, which is combined with clinical information, can calculate the individual patient's risk for high-grade significant prostate cancer. Or we have what we see on the next slide, the well-known PCA3 test to guide biopsy. And again, we see the PCA3 test that is better than total or PSA density or percent-free PSA to distinguish men with negative from positive biopsies. We do have patient tests like the Select MDX test, where we have a combination, the PCPT prevention trial, to predict positive biopsies, initial biopsies. You see it here on the green curve. And we have the Select MDX, which outperforms this clinical model by a significant way. And it's something that's similar to what our target is in this talk. Another slide for the Select MDX in a separate study, but same outcome, PCA3 prostate cancer prevention trial or SELECT-MDx for distinguishing clinical significant prostate cancer. And again, we see the SELECT-MDx test does not perform too bad in this setting either. And likewise, it correlates with Gleason score, where it is low with no, higher with with low risk, and higher with intermediate to high risk prostate cancer. Or we have the problem with similar markers, and we have to realize when there's multiple markers for a similar purpose, can we really tell who's the best in class? Do we have comparative studies? And unfortunately, we have to acknowledge that a real side-by-side comparison between two different markers in identical populations is actually quite rare. We see most of the comparative studies in same population with PCA3 and PHI, most of them. We have one comparison, PCA3 and 4K, and we have one 4K and PHI. And if you look, for example, at the outcome, the errors on the curve between here, 4K score and PHI are not too different in identical populations. So we have to keep this in mind that we have an array of different markers for the same purposes, and it's hard to tell at this moment whether or not there's one marker clearly superior to the other one. Another word I have to mention is we all have now been familiar and trained to acknowledge the importance of MRI-targeted biopsies. This is just an example to show that when you use your MRI, and MRI is nowadays recommended, certainly in its repeat, but also in the initial biopsy setting by some guidelines, that if you use an MRI, you increase the ratio of clinically significant prostate cancer detection using MRI and MRI-derived Pirate score. So we have other issues that we need to discuss when we want to say where is the place of EPI or where is the place of a one singular marker at this moment. And I will follow this discussion with this study I'm highlighting here, and I will spend quite a bit of time on that one because it shows, I think, that the scenario we have to face nowadays and the way we are looking at patients with PSAs and their gray zones are going to be more complex, and we will certainly need more than one test to find out what's best. In this study, what you see is that we have a patient population which has a PSA of 20, no previous biopsy, and we have ExoDx and or 4K score and or MRI available. And here in these overlying circles, you see that on the left-hand side is the 4K group, and on the right-hand side, the ExoDx group, that there's a certain group which has all of them. And these ones, we are going to look at it in more detail now. First of all, when the authors correlated the 4K score on the left-hand side and the ExoDx score on the right-hand side with the Pirate score, and you see here in red the threshold or the cutoff of the individual test, we can again see that what we have known before, that the higher the Pirate score, the higher the 4K score, or the higher the ExoDx score is. So we have a nice correlation from level from score to potential aggressiveness. In the very same way, both 4K and the ExoDx correlate with the biopsy result. When the biopsy result is negative, usually the 4K or ExoDx is lower than when the biopsy is positive with a Gleason grade 1 group or Gleason grade 2 prostate cancer. So this basically fits very nicely into the picture what we do. But now the big point is that we do not look at individual things anymore, but that we have to do combinations. And it's likely to assume that combinations are better than the sum of its parts. So what the authors did is basically every possible combination that you can derive from the multiparametric MRI, from the 4K score, or from the ExoDx test, and you have combinations of it. For example, just to give you an idea, if you say we are looking at the algorithm 4, where you say we avoid multiparametric MRI and biopsy patients if the exosome test is greater than 15, if, however, is smaller than 15, sorry, if it's smaller than 50 and smaller than 19, then you would do only if multiparametric is positive. And if it's greater than 19, you would biopsy every single one, regardless of the multiparametric MRI results. So multiple combinations, and you have to define which combinations is yielding the best results. And this kind of busy slides show you what the results will be. On the left-hand side, you see the biopsies avoided based on 4K score only. Or you see it, for example, the biopsies avoided based on PSA density greater than 15 alone, or you have various of the combinations that I've showed you before. And you see here that, for example, the PSA density, which we can easily derive from our TRUS and PSA only, has the strongest capability to reduce unnecessary biopsy by 64%. And this is much better than, for example, various algorithms, say algorithm 2 or 4, which reduce the number of unnecessary biopsies by about approximately 40 or 39%. However, this comes at a price because PSA density alone misses an unacceptable high rate of 36% of high-grade cancers. Whereas if you look at, for example, the algorithms that contain either ExoDx or 4K, have a much, much better, more favorable rate by much lower rates of missing high-grade prostate cancers. So what this basically tells you is that in these specific settings, various combinations are usually more helpful to decide which patient needs a biopsy and which not, than individual markers by themselves. This, therefore, what the authors concluded is that screening algorithms with upfront liquid biomarker testing followed by multiparametric MRI and biopsy at certain biopsy thresholds, these could reduce unnecessary biopsies and multiparametric magnetic resonance imaging and over-detection of Gleason grade 1 prostate cancer. But again, it is important to realize that it's not one piece of information that you need to guide you to the next appropriate step, but usually that combinations are the way to go forward. Therefore, and this is again the most recent, and for example, NCCN guidelines from January 21, we have a high number of biomarkers available at our hand, commercially available biomarkers, and there will be coming more. But currently, the guidelines still say that no biomarker test can be recommended over any other one at this moment. A biomarker assay can be done alone or in addition to multiparametric MRI or refined biopsy techniques, as I've shown you earlier. And at this moment, we cannot tell which is the optimal order for biomarker tests and imaging. Therefore, we have lots of our hands, but we certainly do not have the final verdict yet on the utility of different biomarkers at this moment. Therefore, summary, the ExoDx Prostate test is a non-DRE urine-based liquid biopsy genomic test to assess risk of high-grade prostate cancer in men 50 and older with PSA of 2 to 10, considering initial or repeat biopsy pre-MRI. We have clinical validation studies that support its use for this mentioned purpose. The results of multiple studies demonstrate ExoDx can avoid 30% or more of unnecessary biopsies. It does cover similar clinical patients than multiple other blood or urine-based markers, and the comparative studies that we now have at this moment are limited. I assume that it is very likely that the future will be marker plus imaging-based algorithms to better select patients. With that said, I have some relevant publications right here, and I would thank you for your attention, and please do not hesitate to ask any questions you might have.
Okay, thank you very much for that presentation, Professor Hesse. We have got a few polling questions that we have run through or run by our audience while you were giving the presentation, and maybe we can just start by addressing them.
Yes, of course. Ready when you are.
Your perspective on these. So the first question was, do you agree that that there are men that undergo biopsy who have a low risk of having clinical significant prostate cancer, and additional tools are needed to better risk assess prior to biopsy? Yes or no? And if I can just look up well, maybe you can give your perspective on that first, and then I can see if I can find the outcome of the poll.
On that question, I'm pretty sure that most, if not all, urologists are facing the problem of doing biopsies in men, where after the biopsy result pops up, they said this is maybe a cancer, but that should not have been biopsied, or has been no need for biopsies. So I would expect that the vast proportion of men said of the audience said, yes, there's a need to better distinguish those men who don't from those who need a biopsy.
Indeed, yeah, 100% agreement with that. Kind of a soft question, I guess. So
I was going to say it is, yeah, it's not. I mean, that's why we are here, to face that problem, and that's why it's so well established an issue. Correct.
So the next one was, what is your typical use of liquid biomarkers in the early detection of prostate cancer? And the options were A, no usage of liquid biomarkers, or some usage of liquid biomarkers, or frequent uses of liquid biomarkers. And the answer to that was about 40% said A and 60% said B. So 40% don't use liquid biomarkers, and 60% said some use, but none replied frequent use.
Yeah, I think maybe the question here would be how you define a liquid biomarker in the first place, because in essence, blood-based markers are also liquid. But so I think what the audience is more thinking of is that we are speaking of urine-based liquid biomarkers. And I would say that given the variety of and if we assume that liquid biomarkers is only understood as a urine-based test, then I can imagine that as a relatively high percentage of of doctors don't use urine tests at this point in time. And I can imagine so because I know in Germany, where I'm based, that we have, of course, the man is tested or pre-tested with PSA, and subsequently after PSA, there is also blood-based liquid markers, so to speak, that are part of the decision tree, and certainly not everyone comes in with the urine test that is commercially available at this moment. So I think it fits a little bit how we see our daily practice. Mm-hmm. And I would say it's frequent is something that is understandable as yet, and again, looking at from the experience in our clinic and from what we hear from other urologists, they say it is good, but it's certainly nothing that I would do on every single patient.
Right. Okay. Very good. So there's still room for further expansion of the use of urine biomarkers.
In particular, if we refer to a liquid biomarker as urine-based markers, yes.
Right. So the last question was, would you consider utilizing a liquid biomarker such as EPI-CE as a pre-biopsy risk assessment tool if the data is convincing? And 86% said yes, and 14% said no. So.
Yeah, I mean, I find it quite a soft question again, because if data are convincing, people of course are more happy or more willing, and rightfully so, to follow a new method or new test. And I think we can safely say that had we posed that question a little bit more strict, the answer would have been different. But again, it also says that I assume that the audience and every urologist acknowledges the problem of a sort of poor selection for patients undergoing biopsies if you base it on PSA only, and therefore it acknowledges the need for something else that we put on top to better select the patients.
Okay, then there's a couple of questions here that I think that have come in from the audience that I think are sort of getting at the same thing. One is here it says, is the test only recommended before a biopsy, or could it also be used during active surveillance? If yes, how much time should be between the past biopsy and the urine sample?
I would say we don't have published data on that yet. Clearly, it is if you look at the vast, as I said, if I make you recall that picture initially that said what we expect from a marker for prostate cancer, then clearly, then I also said that we should have a marker that helps us monitoring the disease, and we don't have that information yet on most of the alternative markers beyond PSA, and therefore we cannot provide the answer as yet, but clearly it would be a nice answer to have to sort of expand the use of the test to other than biopsy decision making.
And then I think just while we're at it, because this is very related here, so another one that says, to what extent are there findings with the present genomic prostate score, which is carried out from the patient's histology, to use your EPI-CE test, risk score prostate, as an additional progression test?
We have currently there is no comparison between the two. This would be a study that compares two different markers from two different manufacturers and see what the outcome would be. Such comparative data, as I showed you on my slide, are quite rare, and you are right, from a clinician perspective, from a user perspective, these ones would be highly desirable. And I would like to sort of play that ball back to the manufacturers, that they would agree to support such comparative studies. I know that it's kind of difficult, but it would be certainly shed more light on the comparative efficiency between two markers.
But I can't help but also just plug in here, because this is going in the direction of using EPI in a different setting for post a positive low-grade biopsy and the consideration of active surveillance and all. We do have an abstract on the correlation between EPI and upgrading on RP here at the EAU. So I encourage the audience to look that up.
Maybe can you, it would be nice to have that visible for the audience right now, or maybe is there a chance for the, it will be on the abstract, of course, and on the EAU, and maybe we can later find it if people are interested to contact you, that we can send the abstract out.
Definitely. The number is available on our virtual page, and the abstract number, I don't know if I can show this on screen, or if the
maybe
the organizers can help me show this, but it's the number is P1038.
Let's suppose that. Okay, that's good to have. So again, it shows that for that purpose that the earlier question was intended to, that of course, as time progresses, a marker will be evaluated in various settings, and the most relevant, the biopsy yes or no one, is of course where we start. But as we have seen with other markers, they will expand to upgrading from biopsy to radical prostatectomy. They will expand to active surveillance. Probably they will also show issues like how is the ExoDx test affected by anti-hormonal therapy, which we know so well for PSA and the effect of 5-alpha reductase inhibitors. But similarly, it would be interesting to know that for other markers like the ExoDx, of course.
Yeah, that's actually another question here that came in, which is just simply, can I use this test for patients with patients on finasteride?
I mean, sort of, it's so nice that we've picked that up, because it is exactly what from a clinician perspective, from a urologist patient's perspective, who sees patients with BPH and patients who undergo a 5-alpha reductase inhibitor treatment, it's something that we would be desperate to know, because we need to know the impact of manipulating drugs on a certain marker if we want to interpret it correctly in that specific context.
Right. And yeah, I can add to that yes, you're right. We currently don't have any dedicated studies of this, but we do have a few patients worth of experience from the latest validation study, which is still manuscript in preparation, from a European population, where the use of these drugs were not an exclusion criteria, and there's no evidence or nothing to suggest in that data that there was any interference from the use of them. And since we're not using PSA as part of the risk score, it doesn't, the lowering of PSA doesn't immediately affect the score. But
yeah, so that means just to have the audience a short summary on that one, we have data on patients who are under 5-alpha reductase inhibitor and have an EPI score, but we have no longitudinal data where you say we have an EPI score, then we go ahead with a certain time of 5-alpha reductase inhibitors, and then we have an EPI score afterwards. This is what, so we do not know the changes over time.
Exactly right.
Okay.
Yeah.
I see.
Okay, then there's one here. Let's see if I understand this question correctly. I'll just read it aloud. Congratulations on your presentation, Professor. Could the markers be utilized concerning how to manage a case of rising PSA given that the biopsy has been omitted? Is there any correlation with the risk of prostatic malignancy in the future?
Maybe concern. I'm not quite sure if I understand the question correctly. I mean, in the sense, what the data show is that, and I'm just repeating myself here, that if you do an EPI test, then the score that you receive will give you a chance or a risk of high-grade prostate cancer. What we do not know is if we have sort of longitudinal data again and see that, for example, on time point X, we have an EPI test taken, and for whatever reason, the patient has not undergone a biopsy, and we see the same patient coming back 1 year, 2 or 3 years later, having maybe biopsies and eventually have a prostate cancer detected. So that that based on the early, maybe on the first or second EPI test, that we could already predict that 2 or 3 years down the road, he might have prostate malignancy detected. If that is the question, then to my understanding is that we have no longitudinal data as yet on patients for a couple of years to see how their cancer, prostate cancer, develops, if it does develop. I hope that I've interpreted the question in that sense, and I hope that was a decent answer to that. Otherwise, please feel free to contact us on the booth, for example, or via the link that is that you see on the website.
Yeah, I think that's an excellent point. Just for everybody's information, this recording, the presentation, the Q&A session here will be available in the on-demand section of EAU also after the fact here. So you can revisit it there, or please do come and visit us at our virtual booth. We have a page, a company page in the industry section, and I'd encourage you to visit us there. My contact information is also available there if you want to contact me directly or reach out to Professor Hase.
Yeah, absolutely. Don't hesitate. No problem at all.
I know we're all getting used to, at least I am, this virtual format. There's sometimes it's not completely straightforward to figure out how to get to all the information. But please do come and visit us, and we'll answer all remaining questions if there are any. There's one more question here that we might be able to just touch on, which also covers a couple of questions which have come in, which well, this gets to the same point as how cost effective are these tests? If we do 2 to 3 biomarkers, does the offset the cost of MRI/biopsy and risk of missing cancer?
Well, probably a question that you can create an entire meeting around, from the urologist's perspective, from the patient's perspective, and from the MRI manufacturer's perspective. We don't know that. In the end, if we just make our mathematics as simple thinking urologists, which I'm one of, you would say it costs me X hundred euros or dollar or whatever for an MRI, and it tells me this, and if for this price I could get, say, 2 or 3 liquid biomarkers, and then we can decide what catches eventually more prostate cancers. But this, of course, is a very personal experience and not one that has sort of a solid basis based on the overall use in a certain population. I would therefore answer that we cannot really give you a more or like a cost effectiveness analysis of using this or that or a combination of markers. Certainly what also affects the use of such markers is if they are covered by healthcare, by the insurances. I know, for example, in Germany, it is even difficult to get a PSA test covered by the healthcare, by the insurances. And this might be, of course, an issue that is different in other countries where they are covered. And this certainly has a heavy impact on the application of such tests, because patients they will ask, do I have to pay X hundred euros for an additional test out of my own pocket, and how much more do I benefit from it? And if these questions cannot be clearly answered, then it is difficult for the patient to understand why he should invest a 3-digit euro or dollar amount for a test. But again, it is probably a very, very good question in the end, because whatever we come up with data and saying we have tested X thousand patients with this, what is the financial upshot or downside for those who have to pay for it in the long perspective, that is really unknown.
And without providing the final answer to that very good question, of course, one important piece I can answer, which is related to another question that came in, which was simply how much does it cost and where can I get it? The answer to that is around 300, depending a little bit on so around 300 euros, depending on a little bit on the country and the distribution. Currently, the test is available from the clinical laboratory of Exosome Diagnostics in Germany, and we're working with different partners in different countries in Europe to make it available. But please do contact us at the booth if you have more detailed questions, and we'll make sure to hook you up.
If somebody from non-Germany would like to have that test, can he send it, or can he order it through the German base and send it back to you, or does he have to actually wait until it is available in his specific or her specific country?
No, it can be ordered through our laboratory in Germany, but depending on the geography, we'd have to figure out the logistics of every single individual. I'm not sure if we have reached into every corner of Europe yet, but it is available.
Maybe can you just shortly mention you order a test, which means you will receive like a package and then you send it back. Is there anything that needs to be considered in terms of shipping, like temperature or anything, or is it you just simply put it into an envelope and hope that the urine vial doesn't break?
No, it has to be shipped cold. So if you order a test, there is a test or sample collection kit that gets sent out, which has everything you need, including cold packs to send the sample back. Has the sample collection device and the cold packs to keep the return shipping cold.
Okay.
And then one last question that I think we can still make, which is sort of related to what we just talked about before, is what is the best way to risk stratify patients to determine who needs an MRI?
Yeah. Again, million-dollar questions. Where do we start? No best answer yet. Usually in our daily work, you don't see a patient coming to or most people have a PSA. So there's basically no way of avoiding a patient discussion and how to proceed next without having a PSA. So now your PSA gives you one factor that you consider, and then you have your age, DRE findings. Maybe you do a trust on the patient. You have family history and ethnicity in there, and then you decide for the next step. Currently, what we have to realize is that the guidelines suggest that MRI is definitely to be used in the second or in the repeat biopsy setting, and that is again a decision that it's easily to understand because you have gone through all your clinical variables like age or family history, etc., and still have persistent suspicion. But likewise, the MRI is now also heavily into the initial biopsy scenario. So take the same variables. If your level of suspicion is high, then go for an MRI rather than not doing it. And remember that the MRI is one option that gives you a picture, whereas biomarkers, blood-based or urine-based, give you another sort of piece of the puzzle. And based on the possibilities that you have, the availability and the financial possibilities for the patient if he's not insured, you need to put that puzzle together in certain ways to find for each specific patient the best solution. But that is why I showed you these. I spent quite a bit of time on that one study where we have really combinations of urine and blood-based markers and of MRI, because eventually we will end up somewhere there that we will use a combination of both to tailor the next step for each individual patient better.
Okay, thank you very much, Professor Hesse, and thank you very much to everybody who participated here, and thank you for all the questions, which unfortunately we haven't been able to make it through all of them, but we're running out of time here. I would really encourage you to come look us up at the booth, the virtual booth, or our company page in the industry section of the EAU virtual website. And we'll try to answer the rest of your questions as best we can, and we've got plenty of time during the conference. But for now, we're gonna have to end it here, and I'll just say thank you again to everybody, and thank you very much, Professor Hesse, for giving us the presentation today.
Thanks very much also from my side. Thank you that you made it fit into the OR break that I have, and thanks to the audience for joining.
I know it's difficult for virtual meetings. The real ones have a little bit more atmosphere, but we do as best as we can to fill the gap as per now. Thanks very much and have a great day.
Have a good one, everybody. Have a good conference. Bye-bye.